Thank you.
Yes, thank you. Thanks for having me. I'm really excited. This program is ridiculous. Like Kay Kirkpatrick's following me, and then the great Brian Sermon. This is, I am honored to be here. My task today is to kind of touch on nerve transfers. These, nerve transfers are these things that have probably been popularized over the last 10 years or so by this lady in St. Louis named Susan McKinnon, who is a definite kind of rock star in hand surgery. And these things have gained a lot of traction as a great option for nerve problems, largely traumatic nerve problems, but to some extent kind of compressive neuropathies also. So hopefully, you guys stop me wherever and we can talk about whatever you want to talk about, but I'll kind of run through this. There are a lot of slides. We don't have to get through all of them, and we'll kind of touch on nerve transfers and then tendon transfers to some extent also. So, the problem with nerve reconstruction in general is that you are on the clock to some extent. You have about a year to get reinnervation back of a muscle, maybe a year and a half if you're lucky, before the motor end plates start to shut down. The acetylcholine receptors are kind of the culprit in this. They degrade after about a year to a year and a half. And so if you don't have some sort of nerve fiber, action potential going to this muscle within about a year to year and a half, you're not going to get any functional muscle regeneration. As you guys all know, axon regeneration is probably 1 millimeter a day, to be honest. And if a muscle is 50 centimeters from a nerve injury, it's not going to be innervated by a year. So that kind of throws out everything in the proximal arm in adults. Kids are a different story. As you guys who work with kids know, their arms are shorter, but their nerves grow at the same speed, and they just have better healing potential and all that sort of thing. So they are at a much higher chance of having functional nerve recovery than adults. This is the situation we're in. Muscle fiber atrophy and end plate changes are relatively rapid, but nerve recovery is very slow. It's something we're working on in the lab and maybe making some progress on. But the problem with lab research on nerve regeneration is that rats, mice, and even pigs have dramatically better nerve regenerative potential than humans do, and so the kind of translation isn't quite there. We have some great kind of putative factors that increase nerve regeneration in animals, but because we haven't proven anything in humans necessarily yet, unfortunately. And things like, electrical stimulation and that sort of stuff of nerves, we've proven pretty well in rats, but we think that stimulating the nerves prior to transection is the key to having some effect with electrical stimulation of nerves. And as you might imagine, that's not exactly possible in humans where that's not a thing. So surgical options after neurologic injury, just repairing the nerves, neurorrhaphy, nerve grafting, sural nerve or what have you, tendon transfers, arthrodesis, and I'd also like to add into that category, replacements like arthroplasty, particularly total shoulder arthroplasty is a great option for shoulder problems. We have a great case coming up soon that some of you, or a couple of you will probably see, where we're a guy with an upper trunk brachial plexus lesion like C5, C6 has a completely flared shoulder, but great elbow and finger motion. And so we're going to take, and his pectoralis is working well, so we're going to take his pectoralis and use that to replace his deltoid as kind of like a rotational flap on its like nerve and artery, and then do a reverse total shoulder underneath that and see if this works. It'll probably be one of the first few in the country to do this. They've done it at Mayo a couple times, and Dr. Wagner, who I think has spoken to you guys in the past, and I are doing it together, so stay tuned on that. There are great studies for upper brachial plexus palsy because, as you know, the target organ is so far from the lesion that demonstrate that nerve transfers have a dramatically better functional outcomes than nerve grafting in adults. That's a well-known sort of thing. So for those of you who aren't familiar, or maybe less familiar, nerve transfers in general are where we take a functional nerve that kind of like dually innervates either a function or a muscle, and transect it and transfer it to the nerve that's not currently working. And the kind of things that we think of in our mind when we're making these decisions are how long has it been. If it's been more than a year to probably more than a year because you need some time for recovery, you sort of can't do it. What do you have that works and is either dually innervated or has a redundant function? What do you need? What's available for safe transfer? And obviously you have to have a nerve that is going to reach. We also sort of, to some extent, think about the axon count, the percentage of motor to sensory axons available in the donor nerve, whether it's a reasonable size match, and sort of this idea of having some kind of function that matches with the donor nerve. Nerve transfers and nerve grafting each have sort of places in the world in my mind, but the distance to the target is definitely shorter with nerve transfers. You only have one neuropathy site versus two in nerve transfers. The kind of wound bed is much better in nerve transfers rather than nerve grafting, where you're by sort of definition going through some traumatic bed, and also kind of making generalizations. But for nerve transfers, you can definitely you can sort of put them together at maybe a little bit less tension because you're always sort of trying to make the nerve graft as short as possible. But with nerve transfers, you can potentially put them in at a little bit less tension so that you can start earlier range of motion. You don't have as much donor site morbidity like with sural nerve grafting, and the surgical time is potentially shorter. But for both, younger is better and sooner is definitely better. So we'll kind of go through some of the more common nerve transfers. Every nerve that's ever been injured probably has some sort of nerve transfer defined for it. Most of these have only been done, in the hundreds or couple hundred times in the country, so there's no great studies to kind of compare these. We're starting to get there, but we're not quite there yet. So probably one of the most common is axillary nerve injuries, as you might imagine, from revision total shoulder arthroplasties, or from upper trunk brachial plexus problems, or any number of other issues. And the most common nerve transfer to restore deltoid function is taking one of the three branches of the radial nerve that goes to the triceps and transferring it over to the axillary nerve. And oftentimes we sort of transfer it over to the bifurcation the bifurcation of the axillary nerve where it's about to branch into teres minor and deltoid. And as we'll kind of talk about in a second, the second shoulder issue that goes kind of hand in hand with loss of deltoid function is loss of the suprascapular nerve function, particularly the supraspinatus and infraspinatus. And there's some thought, although increasingly less so, thanks to a lot of Dr. Wagner's research, actually, that this cranial nerve 11 nerve transfer, suprascapular nerve, is a reasonable option. But I think there's increasing data showing that this lower trapezius transfer that he may or may not have sort of talked about is probably a better option and is more reliable at restoring external rotation particularly. So this guy had limited abduction of his arm. As you can see, we took one of the three branches to the triceps, one of the three branches of the radial nerve of the triceps, and transferred over to the axillary nerve. And he did reasonably well. Can you guys see okay? That's
better.
Okay.
I don't know where the other light is. Right behind me.
Is that better? Okay, good. And then the suprascapular nerve transfer. So the one of the best things in my mind about nerve transfers is that you typically don't burn a tendon transfer bridge in the future. If you do a nerve transfer early, you can always go back and do a tendon transfer later. But the one exception to that is this transfer. The transfer to the suprascapular nerve when it's injured takes the distal portion of the spinal accessory nerve, which innervates the lower portion of the trapezius muscle. And so in this case, you got to either kind of pick one of the two, either this lower trapezius transfer, which we think is probably a better option these days, or a spinal accessory nerve transfer. In younger patients, maybe a spinal accessory nerve transfer is reasonable, but of all of the nerve transfers that we do, this is probably the least reliable, we think. There are about 8 studies on these things, a total of 123 nerve transfers, which is a lot. These are probably the most commonly done of the nerve transfers. and 73% have M3 strength, which isn't really saying a lot and probably overselling it. This is Dr. Wagner's thing. I'm sure he had about 1,000 slides on this, but this lower trapezius transfer is a really good option that we're doing both for brachial plexus problems and also just general irreparable rotator cuff tears these days. Musculaneous nerve transfers to restore elbow flexion are one of the best nerve transfers that there are. These almost uniformly work, are a very elegant surgery, work reasonably well, and don't have a lot of donor site morbidity. And so the kind of classic transfer was the Oberlin transfer, where we took the fascicle to the flexor carpi ulnaris from the ulnar nerve and transferred it over to biceps branch of the musculocutaneous nerve. But this woman who sort of led the charge on this thing, Susan McKinnon, has become a proponent of doing what we call like a dual nerve transfer, transferring over a nerve from the fascicle from the ulnar nerve to the biceps, and also transferring over a fascicle from the median nerve, like FCU, to the ring finger. We try and like tease that out as much as we can, and transferring that to the brachialis. And that's great when you have a lesion that sort of involves only elbow flexion and you have intact median nerve function and ulnar nerve function, but a lot of times you don't, and we're stuck doing other things that are not as good, like intercostal nerve transfers or spinal accessory nerve transfers, which, as you might imagine, that's quite a reach to get down to the biceps and brachialis. There aren't a lot of great studies on any of this stuff, but the results are definitely better than any tendon or nerve transfer for elbow flexion strength, we think. And this is that double fascicular transfer that Susan McKinnon is a proponent of, and has a reasonably good option. At 5.5 months, 6 patients all had M4 strength and no weakness in their hand as a result. And that's the median nerve, flexor digitorum superficialis fascicle, and the ulnar nerve, flexor carpi ulnaris fascicle, being transferred over to biceps and brachialis respectively. So, some good studies on this. I guess all 26 studies combined, there's a total of 955 transfers done, which probably is a significant proportion of the transfers that have ever been done. And then sort of kind of marching on down the arm, this anterior interosseous nerve to ulnar motor nerve transfer is a pretty common thing that I think a lot of you hopefully have seen these days because it's sort of easy. The results aren't terrific, but it's probably better than anything else we have for ulnar nerve problems in the hand. As you know, you get ulnar claw hand after ulnar nerve lesions, and we take the anterior interosseous nerve right before it innervates the pronator quadratus and transfer it over to the motor portion of the ulnar nerve. There are great sensory nerve transfers that you can add along with this motor nerve transfer, but this motor nerve transfer is just the to attempt to restore some intrinsic muscle strength in the hand. Not great. It's a longer distance to the target organ, 12 centimeters to ADM, 18 centimeters to adductor pollicis. So it's still shorter than other options, but not great. Outcomes aren't great. Kind of nerve problems in general are very difficult problems. I'd love to sort of hear your thoughts on them at some point afterwards or anytime. And nerve transfers have improved outcomes to some extent, but they certainly are not, as of yet, the perfect solution. And sort of the key to these things is the sooner we get to them, largely the better. We want to give these patients time to recover if they're going to recover, but we need to sort of make a decision sooner rather than later on whether or not they are actually going to recover on their own. Patients definitively have a better outcome if they recover on their own than if we do something to them. That's largely because the patients that we do something to are more badly injured, I think. So, we need to be on top of these people. So, if there's any way we can help you guys sort of sort this out, we're always available to help. I think therapy after nerve transfers is extremely interesting, and I'm certainly not the expert on these things. But There are some good papers on it, and I think it would be really interesting. You know, they kind of use mirror therapy to work on cortical activation. I don't know if any of you guys are doing any of this stuff at all, but they're using surface EMG biofeedback, and then sort of using the same surface EMG biofeedback to try and avoid co-contracting the donor nerve while contracting the transferred to muscle. And then kind of moving on to just ADLs and that sort of stuff. But this is super cool stuff from a therapy standpoint, and it would be exciting to kind of, you know, find whoever's interested in this thing and sort of start studying it. I think Dr. Gottschalk is on the schedule at some point to talk about compressive neuropathies of the arm, and I think I would just talk quickly about tendon transfers and other options. You know, sometimes people get lulled into this sense of like, there's nothing we can do for you, and I hate that, particularly when there's great options for people down the road if there are tendon transfer options and those sort of things. And so I don't, you know, and maybe we can just kind of touch on these things quickly so that everybody's sort of aware that there are things we can do down the road if, you know, release of compressive lesions of the peripheral nerves isn't particularly helpful. You know, for carpal tunnel syndrome, there's some great options. We can take flexor digitorum superficialis, usually to the ring finger, and transfer it over to restore thumb opposition, either through a pulley in the palmar fascia that you can kind of see right here, or through a pulley made in the FCU over here. We can take flexor extensor digiti indicis from the index finger and transfer it around the ulna, also to restore thumb abduction, or this so-called Huber transfer, where we take the kind of hypothenar muscles, abductor digiti, to the small finger and move it over to restore thenar musculature. That's kind of a big surgery, but a described option. And probably my favorite, because it's through the same incision as the carpal tunnel release, is using the palmar fascia and its extension into PL to transfer it over to kind of the ulnar aspect, or I'm sorry, the radial aspect of the thumb to restore thumb opposition. That's, you know, probably the easiest in my mind, the most kind of appropriate, because it's a very expendable tendon, and through the same incision and all that sort of stuff. So, you know, this is us kind of harvesting this thing, transferring it over, and, you know, the thumb in a much better position. For cubital tunnel syndrome, there's actually reasonable evidence out of these folks in St. Louis that this end-to-side anterior interosseous to ulnar motor nerve transfer can be a reasonable option even in compressive neuropathies that have been going on for years, to try and give something back to the hand intrinsics. You know, there's some idea that there are sort of enough signals flowing through the ulnar nerve, even in the worst of compressive neuropathies, to sort of keep the motor end plates at least reasonably alive. And this study looks at ulnar nerve palsies from a number of etiologies, but about a quarter to a half are from chronic compressive neuropathies. And they're a proponent of, in people with significant intrinsic wasting, at least attempting an end-to-side ulnar motor nerve transfer in conjunction with release of the cubital tunnel. It's you know, an easy procedure through a reasonably small incision with low donor site morbidity, and may be worth a try. You know, we've sort of seen this in the past, but that's that interosseous nerve going into the pronator quadratus. Pronator quadratus all right here, anterior interosseous nerve running along with the anterior interosseous artery and its veins. And then you can sort of tease out the motor branch of the ulnar nerve from the sensory branch of the ulnar nerve, and plug those two in, that anterior interosseous nerve to the sensory branch, to the motor branch of the ulnar nerve. And, you know, again, outcomes aren't perfect, but it's something. Probably, you know, and as we know, sort of tendon transfer for ulnar nerve problems are not the end-all be-all. As you guys know, MP hyperextension is probably the problem in intrinsic or in chronic ulnar nerve problems. And there are a lot of great options or a lot of reasonable options for it from a tendon transfer standpoint. This brand transfer, where we take extensor carpi radialis longus or brevis and some palmaris tendon graft and route it under the intermetacarpal ligaments and attach it to the intrinsic musculature or the base of the proximal phalanges and sort of really just provide some sort of dynamic splinting of their MP joints and a little bit of flexion. I think we're fooling ourselves if we think we're really restoring intrinsic muscular function. We're really just kind of splinting their MP joints down a little bit, I think. There are other good kind of variations on the same theme where we take flexor digitorum superficialis and either attach it to the bases of the proximal phalanges or into the intrinsic musculature, and they work reasonably well. Here, this is the so-called Zampoli lasso, where we take flexor digitorum superficialis and just wrap it around A1 and or a little bit of A2, and also just sort of holds the MP joint down in a little bit of flexion so it can't go into hyperextension. And I think I touch on it later, but sort of the way we decide whether or not we can just sort of splint their MP joints down a little bit is by this Bouvier maneuver, where we flex their MP joints down and see if their PIP joints straighten out all the way. And if, when we bring their MP joints down, their PIP joints, their intrinsic musculature has enough tension that their PIP joints get straight enough that they have a reasonably functional hand and are in a good position, we can just treat the MP joint alone without having to sort of sew these things into the intrinsic muscles. Because the intrinsic muscles of the fingers, as much as we pretend like they're this really stout structure, are very wispy, and trying to do a tendon transfer into these intrinsic muscles is challenging and probably not the most promising thing. So there are other great things like thumb adduction is obviously a problem in ulnar nerve issues, and you can take ECRB and some tendon graft and try and reconstruct that. This so-called Wartenberg sign some people complain about. There is a described tendon transfer for this, where we take a little bit of extensor digiti minimi, flip it around underneath the intermetacarpal ligament here and attach it to the opposite side, the radial side of the proximal phalangeal base. But that seems like a little bit of overkill for a largely cosmetic problem. So, tendon transfers in general, we sort of touched on them from a compressive neuropathy standpoint, but we'll kind of quickly go over the various tendon transfers for radial nerve palsy, median nerve palsy, ulnar nerve palsies, and sort of the principles of anatomy and that sort of stuff. The goals are to restore balance to the hand, preserve or restore function while preserving the aesthetic and maintaining their hygiene and that sort of thing. So this was this lady who had some attritional ruptures from tenosynovitis of the dorsal hand from rheumatoid arthritis that just had long finger and ring finger, inability to extend the long and ring finger, and just side carded those long finger to the index and ring finger to the small finger, and she has a beautiful result. There are other reasonable alternatives to tendon transfer, like primary or secondary tendon repair or intercalated grafting, which I think are reasonable options while probably underutilized, because if you want to sort of restore independent finger motion, those are probably the only options. Nerve repair, nerve reconstruction, nerve transfers, arthrodesis, and arthroplasty. So the risks of tendon transfer are obviously that you lose the independent motor, particularly with side carding extensor tendons to each other. You lose independent digital flexion. You can get a swan neck deformity if you're taking flexor digitorum superficialis. You almost always get decreased grip strength when you're using a tendon transfer. And there's always the possibility that the transferred tendon that the tendon that your transfer is unable to perform. So to sort of make a decision on this thing, on whether or not to do a tendon transfer, you need to kind of check these boxes, including having mobile joints, restoring soft tissue equilibrium, not having a scarred wound bed, having nice supple skin to work through, having expendable donor tendons, having reasonable recipient sites, having appropriate, sort of matching the strength of the donor tendon to the strength of the recipient tendon, having an appropriate amount of amplitude of the tendon muscle unit, pulling in a reasonable direction that somewhat restores its function. And you want to sort of adhere to this idea of having one tendon and one function, rather than trying to do two different things with the same tendon. We think when we're thinking about which tendon to transfer, we sort of ask ourselves whether it has enough force or not, which is a function of the cross-sectional area of the tendon, as every time that these tendons are transferred, regardless of what they are, they always sort of lose a grade of muscle strength. And the other thing that we need to think about is the amount of excursion of the tendon, like wrist extensors and wrist flexors, for example, have nowhere near the excursion of finger flexors at like 12 centimeters, the other thing that we're always reminded of is, particularly in traumatic situations, is that the wrist motion and tenodesis of the wrist plays a huge role in sort of salvaging a maybe questionable tendon transfer. If you can sort of get them in some reasonably static position and are able to use you're able to use wrist flexion and wrist extension largely to your advantage. And in these sort of traumatic scenarios, it is really worth sort of avoiding wrist fusion and trying to preserve any wrist motion that you can, because not only is it going to help with your wrist motion, as you guys know, wrist motion largely or probably doesn't matter so much from a functional standpoint, but if you can get some more finger motion out of it, that's a big win. This is a graph of the various forces of muscles and the excursion of each of the muscles. Digital flexors, maybe more than 7 centimeters. But the best amplitude is probably this, the gracilis muscle, which we hopefully use sometimes for reconstruction of late nerve and tendon problems as a free functional muscle. And the good thing, I guess, about tendon transfers is you can do them anytime. There's no, I always tell patients that you don't burn any bridges by waiting on tendon transfers, and you definitely don't as long as you can maintain supple joints. For nerve transfers, you sort of want to wait as long as possible, and after a tendon transfers, you want to wait as long as possible. And after a nerve injury, I make them wait at least 12 months with no documented recovery, because there's just no benefit to jumping in that pool any sooner. Rheumatoid patients, maybe a little bit different story. If they're continuing to rupture, that something probably needs to be done so that they can avoid future ruptures, whether it's a tenosynovectomy, taking out their distal ulna, or what have you. But from a nerve injury standpoint, waiting is definitely the name of the game. Every tendon transfer that you can imagine has been described, but there's some really good tendon transfers that are the tried and true sort of tendon transfers, like for radial nerve palsy. You have to sort of make the diagnosis first and then figure out whether it's going to resolve or not. These so-called brand transfers, the name of the guy who came up with these things, are the probably poster child for tendon transfers, as they do exceptionally well. We take pronator teres to ECRB to restore wrist extension, palmaris longus to extensor pollicis longus to restore thumb extension, and FCR to all of the EDC, or potentially FCU, to all of the EDCs to restore finger extension. As you guys kind of know, the finger flexors are this very highly orchestrated, and they don't have a lot of tolerance for, contracture and that sort of thing, but the finger extensors are largely just this sort of elastic band that allow your finger flexors to work. So if we can sort of tether the finger extensors even a little bit with this semi-dynamic transfer, people do very, very well. Median nerve palsy, more of a problem. We've sort of touched on it a second ago. High median nerve palsy has a significant number of, it supplies a large proportion of your hand. Low median nerve palsy, a little bit more of a solvable problem. Low, by definition, below the anterior interosseous nerve, you lose sensation and you lose thumb opposition. For low median nerve palsy, you have a lot of stuff available to use. You don't have that many problems, and so you can really do some good for these people with sort of the things we've talked about earlier: flexor digitorum superficialis, EIP, or this Huber transfer, or probably less so in nerve injuries rather than carpal tunnel. But this transfer with palmaris longus and palmar fascia is also a reasonable option. High nerve injury, obviously more of a problem. All the FDSs are out. FDP to the index and middle finger, sometimes the ring finger is also out. Flexor carpi radialis is out. Flexor pollicis longus is out. And so as far as muscles you have available, you have brachioradialis, ECRL, ECRU, but you should probably be careful about using any FDPs as they're the only muscles still working to flex any fingers, and FCU is the only wrist flexor that's still working, so you should not transfer those. So the most common transfers that we do for high median nerve injuries are side to siding FDP to 2 and 3 to 4 and 5, and ECRL to FDP 2 and 3 can add a little bit of power, and brachioradialis to FPL is a reasonable transfer. And this is kind of a picture of that, and it works reasonably well, but not great. Low ulnar nerve palsy, you lose thumb adduction, index finger adduction, that first dorsal interosseous, and you lose a lot of your power grasp from FDP, as you know, to the strong fingers, the small finger and the ring finger, and you lose this kind of coordination of your cylindrical grasp, and you get clawing of your ring finger and small finger, particularly in low ulnar nerve palsy as opposed to high. As you guys know, Swartenberg sign is the adduction of the small finger froments, is that you're losing IP flexion during key pinch, and there are a bunch of other sort of mundane eponyms for these problems. But in low ulnar nerve palsy, you have a lot of things available, all these radial innervated muscles and median innervated muscles. So restoring key pinch is a reasonably doable task with ECRB, with a graft around the third metacarpal, as you sort of see here. And this index abduction you can restore if you choose to with EIP to the first dorsal interosseous, or brachioradialis, or APL. The claw thing, as we sort of talked about earlier, is more of a challenge, and I'm not so sure that tendon transfers are dramatically better than just splints for this problem. But if people really can't, I make everyone get a splint and at least try it for when they have clawing of their fingers. And if they hate the splint and can't wear the splint and really want something else done, but like the position that the splint puts their hand in, then there are great options. MP capsulodesis is something that we can do to, all of these sort of are variations on putting the MP joints down in a little bit more flexion. MP capsulodesis is a reasonable option, but everyone says that these stretch out over time. I haven't been around long enough to see them stretch out, but that's what they say. MP bone blocks are putting a little bit of bone back behind the proximal phalanx such that it cannot extend on the metacarpal head past a certain point. And dermodesis is literally taking out a chunk of skin and causing like a contracture of the skin to keep the MP joint flexed down. And then there are these quote-unquote dynamic transfers to restore, to improve clawing of the hand. But I'm not so sure they're as dynamic as we sort of pretend like they are. And you can take FDS and split it to the lateral bands. You can do the Zancoli lasso thing where we take FDS and divide it distally just past where it splits into two slips. If you, or just proximal to where it splits into two slips. If you divide it distal to that, you can't get IP joint hyperextension, so they say. And you take that FDS that you've then freed up and pass it and kind of just sew it over top of A1 and a little bit of A2 if you wanted to hold the MP joint down and a little bit more flexion. And you could take ECRB, the so-called brand transfer, a brand four-tail ECRB through the intermetacarpal spaces to the lateral bands. And if you have four-finger clawing, that's the only tendon transfer that does not decrease grip strength is using ECRB, so they say. And they have these less dynamic, but also supposedly dynamic tenodeses, where they just take palmaris longus through extensor retinaculum to the lateral bands, and supposedly use sort of the tenodesis effect of the wrist to regain some dynamic MP joint flexion. This is that brand transfer just going to the ring and small fingers here. And this is sort of the thing I spoke about a second ago. It's this Bouvier maneuver where we bring the MP joints down into flexion and see if the IP joints are fully extended or the IP joints remain not fully extended with MP joint flexion. And this supposedly helps us make a determination on whether or not we can use one of those static transfers, like just doing a capsulodesis of the MP joint versus doing a dynamic transfer. But in my mind, doing a dynamic transfer and attaching it to the lateral band is probably a more reasonable sort of option in a lot of people. And particularly if four fingers are involved, that brand transfer using ECRB is probably, in my mind, the best thing. If it's a partial nerve injury, which I had one of the other day, and I'm sure one of you is probably seeing, you can certainly just do one. I did a Zancoli lasso, that FDS over the A1 and A2 pulley thing, just because his only finger that was affected was his small finger, and it didn't make a lot of sense to sacrifice something from another digit or the wrist for just one finger. But yeah. So high ulnar nerve palsies, same transfers for low ulnar nerve palsies, except you have the additional deficits of the FDP to the ring and small finger and FCU. And so FDS to the ring and small finger are the only things working. So you should really avoid using them. And sort of lastly, this idea of rheumatoid hand, we're sort of lucky maybe in my generation, or unlucky, as these are pretty good cases, but these rheumatoid arthritis is largely kind of going by the wayside as a result of great medicines for it. And we don't get to see a lot of this, but we see a little bit of it. And caput ulnae obviously causes ulnar to radial sided extensor tendon ruptures. You can get extensor tendon subluxation and synovitis and potentially posterior interosseous nerve compression at the level of the elbow from rheumatoid arthritis. Probably the most common thing is this caput ulnae, where you get extensor tendon ruptures as a result of synovitis and prominence of the distal ulna. And there are great tendon transfers for these problems, but none of them are perfect. So that was a lot. This is a great, this is an exciting topic. I think, tendon transfers are really good, tried and true sort of options for these problems. But sort of the new cutting edge solution to these peripheral nerve problems are largely nerve transfers. And if we are lucky enough to sort of, through the next 30 or 40 years, make a little bit of headway on improving nerve regeneration through medications or what have you, I think that will sort of be this, the solution. So that's all I've got for you. Any questions? What can I answer? I'm going to turn some lights back on here. Maybe. Anything I can answer? Any questions? Yeah, sure.
How do you do an axon count?
Right, great. You can cut a piece of nerve out in the lab or in the operating room and send it to the pathologist, and they can actually stain like motor and sensory fibers and give you an axon count under the microscope. But largely these are just kind of like numbers that are put in the textbook from just knowing what each nerve's kind of average axon count is. But they used to, kind of in the early days of nerve transfers, they would count the number of axons. They would send these things to the lab and count the number of motor axons and all that sort of stuff. We largely have sort of abandoned that because we have good kind of baseline data on what each nerve has in it. But What else? What have any of you guys seen nerve transfers and have any sort of thoughts on them or how well they're working out in the world?
What did you say you used for the ulnar nerve, for the cubital tunnel?
Yeah, it's this. It's this anterior interosseous nerve. It's right at the level of the wrist, right before it goes into pronator quadratus. You know, you have great pronation function from pronator teres, and so you don't really need pronator quadratus for pronation of the forearm, and so that's a totally expendable muscle. And so we take that anterior interosseous nerve going into the pronator quadratus and transfer it over to the ulnar motor nerve, and it probably doesn't have the right number of axons. It probably has less axons than the ulnar motor nerve does right there because it's only supplying a small muscle, but it's sort of the best we've got, you know.
Would it be possible to go further up and take some fascicles for the EDQF or something, or one of the antagonists of the intrinsics to actually weaken them to decrease the...
Yeah.
Because what we see in therapy a lot, even with therapists that work hard to know what they're doing, is that the patients are trying so hard to straighten their fingers that they're actually strengthening the MP extensors, which actually worsens the dysfunction.
Yeah.
And so I'd actually talked to one of the physiatrists at the VA about even the possibility of weakening the MP extensors, maybe with Botox or something, to get a better functional outcome. And I was wondering if we could organize the nerve transfer in order to not just strengthen the intrinsic, but weaken its antagonist.
Yeah, that's interesting. It'd be it's an interesting idea. It'd be a long reach for that nerve probably, but weakening them with Botox or something like that would definitely be a reasonable option. Yeah. Are any of you guys doing like mirror therapy or seeing success with those? Yeah. And how about like surface EMG? Is anybody doing biofeedback, those sort of things? That's cool. All right, that's awesome. I don't know how prominent how prominent do you guys all have surface EMGs in your clinic, or do some people? You do?
Something else.
Something else. Interesting. Like for biofeedback purposes, or for? Oh, cool. Okay.
I feel like it's almost essential.
Really?
Yes, particularly for tendon transfers.
Yeah. Interesting. Cool. You know, I should sit in the audience and let you guys give me a talk on therapy for tendon transfers. What else? You know, I'm always available. I should have put my cell phone number up here. If you guys ever need me, my phone number is 843-906-1027. Please call me or email me. It's CADALY@emory.edu. Anytime. I'm happy to, please call me if my patients are doing poorly. That would be really nice.
I think the hardest thing is patient expectation. They when they hear about tendon transfers, they think that their hand is going to be like their God-given birth hand.
Yeah.
And you spend half of your time explaining to them that it's not going to be exactly like it. You're looking for function. But I've got a guy right now, and it's just like every time he comes in, it's like a broken record.
Yeah. Right, I know.
Perfect, and when
Yeah, I try to lay down those expectations on the front end, but sometimes they just don't hear you, or you're not doing a good job of explaining it, or what have you. I get it. I get the same story, unfortunately. What else? Any other questions I can answer? Anything? We're trying to kind of build this kind of complex hand and upper extremity center at Emory, and we're hopefully making headway at it. Eric Wagner, who spoke here, 2 months ago probably, is a great guy and a great partner of mine, and hopefully we sort of build this kind of complex nerve practice together. He's very interested in the shoulder portion, and I love the hand and forearm portion, so hopefully we can work together well to kind of build this thing. Forever Emory was really great at carpal tunnel releases and like trigger fingers and all that sort of stuff, but hopefully we can sort of make that a little bit, maybe paint a broader swath of things that we do. So. Cool.
Colleague, Dr. Gottschalk, is speaking in October.
Oh, good. All right, that'll be interesting.
So thank you
Yeah.
for all you do.
Yeah, thank
for
you.
our hand community.
Yeah, thanks guys.